Good day. We're still busy with our ESMO series, and today we're going to do the obstetric hemorrhages. We are going to look at hemorrhage in early pregnancy, and here specifically we are going to look at the different types of miscarriages, and also specifically septic miscarriages and sepsis that develops after miscarriages, which makes it the emergency part, which fits in with ESMO. Then we're going to look at antepartum hemorrhage, the two types of antepartum hemorrhage, placenta previa, placenta abruptio, and management of antepartum hemorrhage in general. And then thirdly, we're going to look at the active management of the third stage of labor and specifically postpartum hemorrhage. And again here, the emergency treatment that goes with postpartum hemorrhage. And then fourthly, in lesson 4, we are going to do the injuries of the genital tract briefly. Very briefly, we're going to talk about the amniotic fluid embolism, sepsis, and shock, and the emergency care that go with that. Okay, so as we've said, and this is lesson 1, and we are going to do the hemorrhage in early pregnancy. I'm Anna Nolte, and I'm teaching you this series of lessons as well. Now, if we look at the term miscarriage, miscarriage is used to describe a spontaneous pregnancy loss before the fetus becomes viable. And in South Africa, we talk around about 24 weeks of pregnancy. And we prefer to use the term miscarriage where it happens spontaneously in comparison with the term abortion, which is more associated with the deliberate termination of pregnancy. Now, if we look at the different types of miscarriages, we divide them into spontaneous miscarriages and induced miscarriages, which will then be the group of abortions, which is the termination of pregnancy. Now, when we look at the spontaneous types of miscarriages, we have the threatened ones, inevitable, incomplete, missed, and complete, and we will look at a few of them and the management of a few of them. Okay, the first type of miscarriage that we are going to talk about is the threatened miscarriage. The name tells you exactly what it means. There are signs and symptoms present that indicate that the miscarriage may take place. But in almost 70% of the cases, the pregnancy will progress to full term. So the signs and symptoms are there, and then they usually go away and pregnancy progresses normally. So if we look at the clinical picture of a threatened abortion, we see that the pregnancy have been diagnosed. There was a period of amenorrhea, and now suddenly the patient might start bleeding vaginally. The bleeding is initially bright red, and then it might change to dark brown, specifically when the bleeding is now going away. And the amount of bleeding may vary from a few drops to a constant flow, and it's usually not a large bleeding. And sometimes it is going with some abdominal pain or backache, which might be constant or intermittent. There's usually no history of a rupture of membranes or contractions, and this is very important, that there are usually no contractions. And when one do a vaginal examination, one can see that the bleeding might be coming from the cervix, but there's no dilatation of the cervix, and that's the one very important aspect about a threatened miscarriage. If we look at the treatment or the management of a threatened abortion, the treatment is usually symptomatic and conservative. There's not a lot that's being done. It's usually more attitude of wait and see what's going to do. Now, I'm saying here under my first bullet that there's no proof, and that's been from evidence and research that has been done, that total bed rest or the administration of hormones has any value. And that was usually what had been used in the past to treat threatened miscarriages. It's also usually not necessary to admit the patient to a hospital. So the patient is being treated on an outpatient basis, but with a full explanation, and that's very important, of the situation to the mother, with a very firm injunction, and this is very important, that she has to contact the doctor or the midwife should any change be happening. And this is specifically important related to bleeding and the amount of bleeding. So unless there's a really obvious cause present, no treatment is being instituted. As we say, the patient is being sent home. She is being advised usually to rest a little bit more, but total bed rest is not necessary, and then wait and see what's happening. If the bleeding becomes heavier or was heavier initially, then it might require hospitalization and observation of the patient in the hospital. And in some patients, the pain and the anxiety about this condition, and specifically where it is a following threatened abortion after previous miscarriages, then the patient might also be very anxious. And in that case, it might be necessary to just admit the patient initially to prescribe sedation for the patient. Now, the follow-up treatment after the first initial stages, usually the bleeding, as we've said, goes away. It changes from red blood to a darker blood, and usually then after the bleeding has been disappeared, the patient might return to a normal lifestyle. She should avoid tiring activities and coitus during the first 3 to 4 weeks after the threatened abortion. And she's also been regarded as a high risk for the rest of her pregnancy, as very often, patients with threatened miscarriages might also have a higher incidence of premature labor, stillbirths, neonatal deaths, and fetal abnormalities. So these patients have to be really observed and monitored very carefully. Now, the next group of miscarriages are inevitable miscarriages. It means it's happening in spite of. There's nothing that you can, almost nothing that you can do to stop it. So the symptoms and the signs indicate that the miscarriage will indeed take place. And the miscarriage might then be either complete or incomplete, about which we will talk about just now as well. An incomplete miscarriage usually means that the uterus hasn't expelled all the products of the conception. The fetus might have been born, and as you can see on this picture here, the fetus has been born, but the placenta and the other products are still sitting in the uterus. Now, the assessment of these patients with the inevitable abortion, the signs and symptoms are exactly the same as a threatening miscarriage, but just in a more pronounced form. The pain is worse and colicky. There's now more contraction type of signs, and the bleeding might also be more severe. And on a vaginal examination, and I think that's basically the biggest distinction between a threatening abortion, a miscarriage, and an inevitable one, is that the cervix is open, the cervical os is open, and there might even be products being protruding through the cervix. The membranes might also have been ruptured, and as I've said, the dilatation of the cervical os and the presence of the contractions are the most important criteria that tells us that this miscarriage is inevitable. Now, if we further look at the assessment, if the woman has lost much blood, and that's very possible, it is very important that she should be resuscitated, and if possible, the bleeding being controlled. Now, it's not always possible to control the bleeding, especially if the miscarriage was not complete. The uterus can't, like in normal birth, the uterus can't contract, and that's usually where the bleeding should come from. So it's very important that these patients should be resuscitated. And also, it's very important that the person who contacts the doctor or the midwife first should be told to please keep everything that is passed by the patient and not to clean it up. So every linen, pads, etc. should be kept and brought to the hospital so that the doctor and the nurses can assess the completeness of the miscarriage to see whether there are any products being passed and the amount of blood that has been passed. And then also very important, any signs of, and this for all the rest of the miscarriages that follow, the signs of infection is very, very important, because we will see that infection there's quite a high incidence of the possibility of infection. And if there are any signs of infection, the woman should be admitted to the hospital immediately. And a pulse, blood pressure and temperature and other signs of infection should be monitored very well. Now, management in the case of severe bleeding, and this is not only for the inevitable miscarriage, that's for miscarriages in general, and you will see it's very similar to antepartum hemorrhage in general, and that's basically the management of any case of severe bleeding, whether it's a vaginal bleeding or any other kind of bleeding. Obviously call for help and then stabilize the circulation by giving 2 large borehole cannulas, IV, start with Ringer's lactate, send off blood samples for cross-matching, give as much as possible IV fluids and blood if possible, catheterize the patient so that the output can be monitored, and then always, and we will come to it again and again during this series of lessons, is the potential of coagulation disorders. The moment that the patient bleeds a lot, she loses a lot of her coagulation factors, and that might lead to some coagulation disorders. So be aware of that all the time. Then the active management is to get the uterus clean, in inverted commas, as quickly as possible, to get the products of pregnancy out of the uterus so that the uterus can contract. And the longer the products stay in the uterus, obviously the bigger the chance of possible infection. So if the uterus is larger than 14 weeks, the expulsion should usually be caused by prostaglandins, by giving hormones. Prostaglandins or misoprostol usually works very well in this case. And after the woman has then aborted and the diagnosis of incomplete miscarriage has been made, a curettage should be performed to just also again get the uterus as clean as possible. And then after this, the patient should be very carefully being observed for bleeding. And the uterus should also, the patient should also be observed for other signs that tells us that the uterus has been incompletely evacuated or has been perforated, and that is usually more bleeding, or signs of infection, which tells us that there's infection present as well. Our next type of miscarriage is a retained miscarriage. Now, usually what happens here is the fetus died in utero, but has not been expelled by the uterus. So the woman had signs of pregnancy. She's a pregnant woman, and she might start bleeding vaginally. And after a while, this stops. It almost looks like a threatened miscarriage, and then the diagnosis of a threatened miscarriage is being made. But then on follow-up observations or with sonar examination, it will become clear that the fetus has not grown, or that the fetal heart movements have disappeared and can't be determined with the sonar. And usually, as I'm saying, the pregnancy is not progressing, so the uterus becomes smaller and harder, and at the later stage, there might also be a bleeding, proper bleeding, or a brown discharge may appear. Now, in the case of a retained miscarriage, there are 2 things that's very important here. Actually, 3 very important things. The one is the possibility of bleeding. The other important aspect is that the contents of the uterus, in this case now the dead fetus, is an excellent culture for culture medium for infectious organisms. So infection is a very big possible problem in this case. And then also the absorption of thromboplastic material from the dead conceptors might also cause or lead to intravascular coagulation, afibrinogenemia, and a bleeding tendency. So in summary, coagulation problems. And then also the patient might develop psychological problems. It's very difficult for the patient to accept that the fetus is dead and that she's actually carrying a dead fetus in her body. Now, the way in which this is being managed depends to a very large extent. Some women may abort spontaneously within 3 to 5 days, and in some cases where it doesn't happen, after 3 weeks, the plasma fibrinogen level should be assessed to make 100% sure that there's no coagulation problems, in which active management should be instituted. And I think in most cases, active management is being usually the preferred choice. Then our next type of miscarriage is a septic miscarriage, and this is a very important one. It's a feared complication, and as we've said now in some of the previous miscarriages, it's a risk with any type of miscarriage. And it may also happen in a more modern institution and after optimum treatment. So it's not always being associated by a criminal type of abortion. And the big problem is that the infecting organism has its own pattern of infection, and some have a very specific clinical cause, as namely the tetanus and the gas gangrene. So there are different ways that this can manifest. Now, when we assess these patients, a complete history is very essential because we need to determine where this is coming from. It might be from a normal abortion, as we've said previously, or there is also the possibility that it came from a criminal procedure. So we should look at the possibility of trauma or the signs of the use of chemical substances, etc. And then, very important, the other symptoms that we should look at and for to confirm our diagnosis of a septic miscarriage is a raised temperature of 38 degrees Celsius or more, offensive discharge from the cervix, a high white cell count, signs of peritonitis or a tender mass in the abdomen, and a history of a criminal procedure. Now, the treatment of these cases involves usually two big basic elements, namely the control of the infection and the support of the woman's vital functions because of the influence that the infection might have on her body. So by the control of the infection, obviously antibiotics are essential and are being given immediately in high dosages as soon as possible. And then once anemia or blood gas problems have been rectified, the uterus should be evacuated. This fetus that is causing the problem or causing the sepsis should be removed as quickly as possible. And then a marked improvement should occur within 48 hours after the cleaning of the uterus, if I can call it like this. Deterioration of the patient's condition demands further investigation, and usually either laparotomy or a hysterectomy might be done. Now, the principles of management of a septic miscarriage, because this is again usually an emergency situation, is to assess the need for resuscitation, to recognize severe sepsis and septic shock, and we have looked at the signs there. And then very important is the fluid resuscitation, as we've said, to put up an IV infusion and maybe even 2 lines of IV infusion as quickly as possible to get the patient's blood pressure as normal as possible. broad spectrum antibiotics within the first hour, so quickly as possible, and we give that intravenously, and then to obtain the relevant cultures, so we get a blood or a urine or a sputum monsters to identify the culture so that we can give the correct antibiotics as well and make the clinical diagnosis according to that. And source then the identification and the control to see where it comes from and to decide then whether surgical management is necessary or not. Now, septic miscarriage is a deadly condition, and if we look at the maternal mortality rates, it is one of the aspects or one of the reasons for quite a few number of mothers that are dying during pregnancy. So this is very, very, very important. And that's why I'm saying here under the first bullet that any patient with even the smallest sign of infection must be regarded as a very high-risk case and must immediately be treated as quickly as possible with regular observations and effective antibiotic coverage. And the patient's condition should improve within 24 to at least 48 hours. Otherwise, it becomes really an emergency, and if she's not in a hospital, she should be referred to the nearest large center for intensive treatment. Now, in summary, how do we recognize a complicated miscarriage? First of all, when there's fever, like we've said, when there's warm extremities, fast breathing, increased maternal heart rate, these are all signs of infection, altered mental state, and that is in a serious case, and then eventually also the blood pressure goes lower, and we have signs of septic shock, a lower tender abdomen, and the cervix might be open with foul-smelling discharge. And then there might also be signs of cervical trauma, specifically in the case of a criminal abortion. And that brings us to the end of our series or our lesson here on miscarriages and the different types of miscarriages. So complete your quiz, and then you can carry on to the next lesson.